probably a bit of a stretch to say that I'm doing lots of things in digital health, and I probably don't have, I feel quite inadequate in this kind of company. But I was asked to actually come along and tell you a little bit about my sort of career experience. I took a bit of a wandering path through things and to get to medicine and to start to involve in some digital health stuff in SA. So the brief was to kind of have a chat, tell you a bit about the weird and wonderful ways I got here, and tell you a little bit about the E-Referrals project that Digital Health SA is currently kind of in the process of implementing. So it's a bit of a weird one, and it's a bit of a mishmash of stuff that I'm talking about, and it kind of feels a little bit like a job interview telling you my history of my career development, and I'll try not to think of you as like the world's largest interview panel. But I'll try and also give you a bit of an understanding of some of the things I've learned along the way, and hopefully if you've got any questions, feel free to fire them at me. So, gosh, it's a while since I've used one of these things. Yay, we're working. So I grew up in Adelaide, or Adelaide as we prefer to know it, and I really didn't know what I wanted to do with my career when I left school. I certainly didn't think that I was had an interest in becoming a doctor. That was for way more smart and capable people than me. And I didn't really have any clue. Enrolled in a science degree at Adelaide Uni. Started off doing some computer science. It seemed like the way of the future. This was a very long time ago, like back in the last century. Did a bit of psychology because I hadn't done that at school. And also did some physics and maths and, of all things, geology, which are good field trips. Then, a couple of years into my science degree, I heard about this new program that was starting up at Flinders Uni, which was basically a science degree with what they called a cognitive science major. And I'd been learning a little bit about sort of in my psychology and computing, about machine learning, and was really fascinated with learning about how the brain worked and how you could kind of recreate that in machines. So I switched across to Flinders Uni, went down south and up the big hill, and did a major in cognitive science, which was a really cool course. It was great for someone who's interested in all the things. We got to do neuroscience, physiology, psychology, maths, a lot of computing. Managed to get enough subjects for a computer science major back in the day before they had all these Bachelor of Information Technology and fancy sort of focused coding degrees. And then kind of got to the end of that and went, right, okay, I'm not sure what I want to do with this, but I really like all the smart, clever AI and machine learning stuff. I actually went off to ANU to do an honours year and worked on a project in a lab, a really interesting lab that was based in the biological sciences school, where there was a biologist who was studying honeybees and how they navigate, and also had a team of computer engineers who were really interested in trying to use the information they were learning about how the honeybees navigate and fly and apply that to unmanned aerial vehicles. So they used to spend a lot of time learning how to fly model planes, and that was their work. So I was doing a project with them involving machine vision, trying to set up a way as you could take some video of human gait, like someone walking, and learn to recognise that individual lots of characteristics you could see in the way they walk. Sadly, at the same time, I was also probably more interested actually in some of my co-curricular activities, including kendo, which is a very weird Japanese martial art that no one's ever heard of. I used to spend most of my time doing that. And kind of towards the end of my honours year, coming into the real peak of the dot-com boom in the early 2000s, managed to get a job as a graduate with an American telco based in Sydney. So I actually never finished my honours year and went off and got a job with what used to be known as Bell Labs. It's the Australian arm of Bell Labs, which was part of the American telco, and it's sort of an R&D facility. We were actually focused more on customer relationship management software and a lot of voice over IP. So I spent a few years working there as a software engineer, building software systems around voice over IP, which is now like the core of what we all use every day. Back then it was really new and fancy, a whole other thing of how to engineer it's an asynchronous data transfer protocol and make that work to enable synchronous voice conversations. We've come a long way since then. So that was kind of a really fun time working in an R&D organisation, .com boom. We had the ping pong tables, we had the bean bags, you know, the free soft drinks. We were living the life of the geek kind of culture. I was also one of, I think, about 4 women on a floor of 60 software engineers, which was that was fun, but also kind of lonely at times. But to be honest, after a few years there, I kind of found my motivation dropping. Certainly the .com boom ended, and you know, they started tightening up, and there's less soft drinks available for free, and people were starting to be made redundant. And I was actually finding that it was really hard to get motivated to really put in the effort when the whole concept of what we were doing was really just maximising shareholder value for a big corporate. And I was looking for a career that would give me a bit more meaning in life. I'd always had an interest in medicine, I have to say, but never thought I'd be good enough. When I was looking around for something more meaningful to do, I guess I kind of channeled my childhood, many reruns of MASH and ER, and decided, well, if I don't give medical school a go, I'm always going to regret it. So I applied, and I was accepted into Sydney Medical School. And clearly we were all just as good looking as this cast from the original Flatliners movie, which you're probably all too young to remember. We had Julie Roberts, we had Kevin Bacon, Kiefer Sutherland. Clearly, when I was at uni, we were not that good looking, and we weren't that experimental and did not have quite such a desire to have near-death experiences. But again, med school was really fun. It was a graduate entry program. We had clinical experience from the first week. It was a really diverse group of people, because there were a lot of people who'd had other careers beforehand and had a lot of different experiences. So that was really fun and stressful, as I'm sure many of you will know. Then, in a similar way to I'm sure many people here have experienced, went out into internship. I did that at Concord Hospital in Western Sydney. Did another TV show, All Saints. You're probably all too young to remember All Saints, but that was filmed at Concord Hospital. Occasionally you would have to dodge the cameras as you were running between the wards. Fashion's not so good there, but anyway. Then, towards the end of my RMO 1 year, I went on maternity leave, and during maternity leave, we actually moved back to Adelaide, where we've gone to live from here, and decided to actually go to buy some property and have family around. It's a whole new concept from living in Sydney. I ended up going to return from maternity leave and worked part-time with Flinders ED for a couple of years, doing a couple of shifts a week. Everyone at Flinders ED really is as good looking as George Clooney. It's amazing. I'd like you to take note of the picture of the front entrance of ED that you can actually see, and there are no ambulances around in front of us, so this is a very rare photo. You won't get this now. There are also no people on the gurneys outside the front door, so very historic, that photo. So after working there for a while, I realised I really like being a generalist. I'd also got the chance to use the stunning lack of excellent digital enablement in that ED. We had a custom built, I don't know if you know the DOS-based patient management system. I got really good at that.
At the time.
It was cutting edge. Yeah, that monochrome green and black was fabulous for listing off all the patients and taking them. But we did get to use Oasis for results and for writing discharge summaries. That was very exciting. But we had heard at that time that there was this thing called EPAS coming. There was lots of money being spent on it, and it was going to change the world. It took a few more years after that. I ended up, because I was interested in doing ED training, but I really didn't like night shifts. And I hadn't had an opportunity to actually do much general practice, because it is very hard when you're a junior doctor to get experience in general practice. We used to have a program called the PGPPP, where you could actually rotate through a term out into general practice. Recruited a lot of GP trainees that way, but it was too expensive, so the government cut the program. I decided, well, I'll just apply for GP training, give it a shot, see how it goes. And then I kind of didn't leave. So I went and trained with GPEX in southern Adelaide through the College of GPs. I also got involved with General Practice Registrars Australia, so doing a bit of advocacy work for trainees. That was a really interesting experience. Got some experience on a board for the first time for a not-for-profit, which opened up a whole new world for me. It really got me interested in that health systems and policy and I guess the politics of medicine and improving healthcare. I've just had to include another show, an Australian GP TV show, very, very old. You will not remember this show. It's a classic on ABC. Somehow probably was responsible for a dire lack of GPs currently in our workforce because I'm sure it turned people off. But anyway, then after I finished my training and was sort of finishing up my work with GPRA, working as a contractor GP, my husband, who is a software engineer, actually got a job with Amazon in Seattle. So we moved the family to the US at the end of 2018 and had a really amazing experience there. It was interesting for me learning vicariously how an organisation like Amazon works, and it's a whole other thing. My husband had a great experience. I was being like a stay-at-home mum. This was not a good place for me. I ended up taking a job as an assistant to the school nurse for my kids' school. That was kind of fun. And kind of travelling along, having a nice time, doing some travel, and then 2020 happened and COVID hit. So in February of 2020, I think the first confirmed case in the US was found just north of where we were, in the sort of outskirts of Seattle, and the first aged care facility outbreak occurred in King County, which sort of surrounds Seattle proper. So things got interesting. Kids came home from school, they never went back before we left the US, they were doing online school. But I was really fortunate, and despite being immensely frustrated that I was in the US, I couldn't practice there, and all my friends back here in Australia were happy to deal with this. I actually managed to get an opportunity to work with Public Health Seattle King County, which is our local county public health unit, and get involved in COVID response that way in a non-clinical position. So Public Health Seattle King County is part of one of the biggest counties in the US, and most public health units are based on counties rather. They have a state department, but a lot of the on-the-ground work happens at the county level. So it served the state of Washington has a population of a bit over 7 million. King County is 2.2 million people, so a bit bigger than South Australia, but in an area probably the size of Greater Adelaide. We had an amazing team of incredible people. It's a close association with the University of Washington, which has a fantastic public health school, and we also had some amazing technological expertise at hand. So we had a fantastic data analytics team who worked with, did a lot of work creating dashboards and a lot of really interesting analytics using Tableau, which was actually locally headquartered. And that was a fabulous experience for me, kind of seeing how things worked in the US. I was involved in a team managing COVID outbreak surveillance and investigation in outpatient healthcare facilities. So we would kind of go and follow up where cases were appearing and counsel organisations on how to actually manage contact tracing and infection prevention, that kind of thing. It was quite incredible, and I learnt a lot. Learnt that I had an interest in public health, and felt like I was able to kind of do my bit. It was interesting seeing how response worked in a country where they don't really have much sort of publicly funded clinical care. We were working with a lot of different private organisations, and because there's a lot of privately funded big corporate healthcare, there's also some really impressive, data and digital innovation. So they were already doing video and telehealth before COVID came along. It expanded a lot during the pandemic, but they kind of already had a lot of that infrastructure in place, which was really interesting compared to coming back here. Then at the beginning of 2021, kids have been in online school for almost a year, we decided to come out to Adelaide. I spent a lovely 2 weeks in a hotel room at the Stanford Plaza. I don't recommend that, but it was an experience. And then shortly after that, through sort of people I knew, I ended up working in the State Control Centre for Health and the COVID response in the Department of Health and Wellbeing as a GP liaison. And that was really interesting, seeing how stuff was working there. And trying to be a bridge between SA Health, as this monolith that's very focused on hospitals, and private general practice out there that was very, very unsupported through the pandemic. So that was another really interesting experience. I got to learn how a lot of the state healthcare system works and all the politics and the policy, and kind of really, I guess, built up a burning desire to make things better, particularly that interface of primary care and hospital medicine. So during my time there, I got involved with the COVID response care team that we set up in DHW. So when we opened the borders and our case numbers went berserk, we were providing phone telehealth support. Initially, it was going to be to every person who was COVID positive in the state that we would call, because we were expecting, maybe 300 cases at a time, and it ended up being more like 3,000 a day kind of thing, which is crazy. So we quickly had to implement a whole lot of systems to use the data we had to try and triage and prioritise where we put our clinical efforts. So we quickly put together SMS surveys for people who tested positive to do, so that we could kind of identify who were the high-risk people, and then we would try and reach out to them. We then had to pivot to utilising the National Coronavirus Helpline, and so we became much more of a kind of a reach-in service for the public who, if they had a concern, they could call the National Coronavirus Helpline and then be referred into us for clinical care as needed. So it was quite an interesting way we had to change and pivot and utilise a lot of digital solutions around that, and just kind of do it on the fly. Not in the nice ordered way we would like to do this. I also, over the past couple of years, have got involved with the Adelaide Primary Health Network, and I'm on the board of that, which is really interesting, learning about, more about governance, which I've had from my GPRA board experience, and how healthcare delivery is actually facilitated out in the community, and sort of the funding, the mechanisms that drive a lot of that. I also am involved with the State Faculty of the College of GPs, and currently, as well as working in general practice down in Happy Valley, I work with SA Virtual Care Service out at Tomsley. So I don't know if any of you guys have come across that, but we do, we provide virtual kind of urgent care to people across the state. Mostly working with ambulance crews, we work with aged care facilities, disability residential care, and a lot of regional support as well. We're now also working with Health Direct, so when South Australians call up Health Direct for some advice, if they are sort of in the category of being told, or you have to see a doctor within 2 hours, we know that no one's going to be able to actually achieve that. So they're sent through to our service, and we can hopefully redirect them away from the backup plan, which is usually go there. So I guess all of that has kind of brought me to where I'm working as well, kind of on the side with digital health SA on E-Referrals. So I guess because of the work I'd done in the department as a GP liaison, when they had kind of finally come to the point that they were going to implement a better system for outpatient referrals and move beyond the fax machine and piles of bits of paper that get moved from pigeonhole to pigeonhole and often get lost, they kind of asked if I would be involved in helping to facilitate kind of that engagement with primary care and GPs more generally. So I don't know how many of you kind of have heard of e-referrals and all the outpatient stuff that's happening across SA Health. But the idea is that this will be a statewide system. There'll be a way, instead of GPs sort of typing up a letter, faxing it into one of many random fax numbers, there's actually an integrated HealthLink form that integrates with most GP software and is able to automate the creation of a referral. And most importantly, probably, is that it's also implementing the clinical prioritisation criteria, or CPCs, that a lot of the different specialties across the state are starting to put together as to what they need in a referral for outpatient services. So that's happened across a few different disciplines. I think we have cardiology, maybe gastroenterology. I can't remember which ones we've got implemented as yet. Most of the ones I've been playing with have been cardiology. So that then means that if you're trying to refer into a hospital, there's some kind of set information that they're requesting, giving a clear understanding for as a GP I need to provide to facilitate that referral. The idea is that there's less referrals getting rejected, there's better information, better ability to triage appropriately, and hopefully this will streamline and increase efficiencies and mean that less people are waiting for years to be seen in outpatient clinic. It's been an interesting process. So the project was started in October last year and went live, when was it? It was probably September. The first site went live was at the Women's and Children's. Initial conversations with the team implementing this were saying, well, probably we could get something up and running by Christmas 2022. Clearly that didn't happen. So we're using existing technology, HealthLink, which most GPs already have access to. SA Health already had some skin in the game with HealthLink. It basically provides a portal to kind of gather up the information and send it securely to whoever's receiving it. The challenge has been in a few different places in this project, kind of in the back end of what do we do with the referrals that are coming through to different local health networks. And so we've actually used a Salesforce platform to kind of manage the referrals on the back end. So they come in, it's all managed through Salesforce, new workflows developed so that instead of the admin staff in different clinics having to look at pieces of paper and tick boxes and type stuff into EMR, this is going to automate a lot of the information in Salesforce and then enable a digital workflow so people will be able to triage referrals to outpatient clinics from wherever they happen to be. They don't have to physically go down to the office and do it. It's been a challenge. Probably the biggest challenges have been around the politics, to be honest, and getting agreement amongst different clinical specialties and across different LHMs. And whenever you change a workflow in a healthcare system, there are many people who get very, very nervous. So ensuring that there's clinical safety, ensuring that you're not making people's work lives much more difficult, and has been really some of the key issues that have had to be addressed. From where I've sat as kind of the GP lead on this is probably around making sure that what's designed actually works for GPs. And it's really interesting the stuff you get from hospital systems that comes out and says, GPs can just do this. And then you actually look at it and it just does not make sense. So we've had to involve a lot of GP integration officers across the local health networks and really manage that communication process between digital teams and the clinicians, and I guess the hospital teams as well with their different perspectives. So this is kind of one of their sort of standard slides that the team rolls out, and I'm happy to answer any questions around the project. I'm not great with the back end, but I'm happy to talk through the implications of E-Referrals. I think that just sort of talks about more about the back end of it. One of the key advantages of E-Referrals, I think, will actually be the ability to track and gather data and actually apply some analytics to it. So we'll actually be able to see how fast things are being triaged, how they actually use the data that's embedded in the form that has some meaning to then get information about the content of referrals and then perhaps trace that through the patient journey later on. It's not yet integrated into EMR, but at some point it will be integrated more smoothly with EMR. That's the next stage. So it has a huge potential and a huge power, I think, to improve clinical outcomes and efficiencies in our system, and I think it's going to make GPs' lives a lot better and hopefully facilitate some two-way communication between people in community and people in hospitals. So we've already had some really good feedback from people using it, women and kids, which is really nice. So we'll see how we go with the next LHMs to come on board. We're hoping that Salem will come on board in February next year, and hopefully Karl as well. We have RMC up and running with Glen Malycha as a regional. So yeah, what have I learned in my wanderings through healthcare and my involvement with various digital projects along the way? I have learned that everyone hates their EMR, whether that's in community or whether that's in a hospital. Everyone hates it. I've also learned it's really important to listen to the clinicians, and if you are a clinician working in this space, really make sure your voice is heard. And anyone who has experience in both that sort of healthcare clinical setting and also has an understanding of how, I guess, technology and software systems work is a really, really valuable asset. So you will find yourself in demand and people will want to utilise your understanding of both sides of the coin. There's a lot of people working in tech who perhaps don't necessarily know what they don't know about the clinical aspects of what they're trying to implement. So be the bridge is my tip. So it's a nice picture of the bridge that runs between Denmark and Sweden. Similar but different countries. So I think it's really important to recognise that we're similar but different, and particularly across primary care and hospital. So keep building those bridges, and that's how we make a difference. That was kind of all I had to throw at you, but happy to answer any questions or hear any feedback on anyone who's had any experience, particularly with E-Referrals so far.
Did anyone have any questions?
So in terms of the implementation of this strategy, so do you have some qualitative work in the process to understand what you wanted, what clinicians wanted?
We didn't do any sort of quantitative analysis. We had sort of a group of GPs that we were sort of running things past as we went. There's each of the metro LHMs has a GP integration unit where they have GPs embedded in a hospital system and providing that kind of bridge into their local primary care community and the hospital system. So we've utilised that as well as a few other sort of interested people around the place. We sort of talked to various communities, we've talked to the College of GPs, talked to Clinical Council, I think of the PHN, tried to kind of get as much feedback. It's been pretty consistent what GPs want. They want something that's not going to require them to type up a lot, something that's going to integrate with things that we already do and that's going to allow us to get some meaningful feedback. So just being able to send in a referral and know that it's being received at the other end is a huge step forward as a GP in sending a referral, because it backs things off into the ether because we can't email them. So email just send them to all the time. We don't have secure email in most private practices, and you don't know whether it's been received at the other end. I've certainly had referrals that you chase up a couple of months later and like, what referral? We have no record of it. Don't know. At least now you'll actually get a digital acknowledgement that yes, it has been received at the other end. And you'll know when it's been triaged and that process will be some information along the way.
But does it provide any information back to the GP apart from it was received? So is information coming back?
It will come back with an accepted or rejected. Longer term, we're hoping that there'll actually be a better facility to actually create a two-way dialogue between the hospital clinicians and GPs. So, and that may be, oh, we need some more information. There's kind of a clunky way we can do that now, but we want to be able to sort of smooth out that process so you don't kind of have to keep redoing referrals and resending things. Hopefully reduce, I guess, duplication of investigations and tests and things, and get the right people.
Yeah.